all week by the time I saw him. So right there, what do you think? Self-employed, not working for a week. Yeah, so he's not out there making money. And it's not like he's getting sick leave or anything like that. He's a mountain biker. He hasn't been able to do that in a month because of this condition. His chief complaint, number one, is this constant throbbing in his elbow that radiates into the forearm. He's also got tingling in his thumb and his index. And then he has a constant ache that can be intermittently sharp in the scapula, and he's got tightness and stiffness in his neck. It says all these symptoms are related. So as you look at this picture, what would be your primary hypothesis? How about one person?
C6 schizophrenic.
Okay, so it's C6 radiculopathy. All right. Would we say this is an acute radiculopathy based off of the terminology he's using to describe the symptoms? Or a chronic radiculopathy? So,
Acute.
acute. So the constancy of it, and then constant throbbing, those are words that are usually associated with something that is active. And then he's got, similar stuff here, constant aching. So a C5-6 discogenic with a acute right-sided C6 radiculopathy. So when you go down through this check down, and you're thinking, okay, the joints are another area of the symptoms. We've got the intrinsic joints of the hand, we've got radiocapitellum, radial ulnar, maybe humeral ulnar a little bit, costotransverse joints, facet joints, even the intervertebral joints. Same up here in the neck, facet joints, and as well as intervertebral joints. We know that the neck can refer here, but what else could this be? If this was a separate elbow problem,
Maybe like radial tunnel syndrome or something like that.
yeah, radial tunnel syndrome, just a horrible rip-roaring epicondylitis. So when you decide, I'm going to just rank a few things, what's worthwhile ranking, you'd come up something like what you guys just said. And then if you wanted to throw in, maybe there's a local problem generating the thoracic area, although it's much easier to lump all these together in the first hypotheses, but that's still something you could consider. And then what if it's not musculoskeletal? Gallbladder, liver, pancreas, could be any of those things. But pretty much usually doesn't happen by referring to the right upper extremity. So you're throwing everything in there with the kitchen sink, and you're then going to ferret this out. So this is called script concordance testing. And it makes you think a little bit about the scenarios here. So the primary symptom generator of the form you think is cervicogenic. And cervical range of motion increases the scapular symptoms, but does not change the upper extremity symptoms. So with this scenario, which is certainly a possibility, would you say that does it change your hypothesis? Meaning 0 is there's no change in likelihood. A -1 means you're slightly less confident now that that's the hypothesis. A +1 would mean you're slightly more confident. A -2 is you're significantly less confident in that hypothesis. And a +2 means slam dunk, I think it supports it. What number would you assign that? So you're going to be saying, despite what the person's telling me, I'm going to give it a +2 is I know that the mid-thoracic pain or the periscapular pain is linked to the elbow. But you put it, there's this chance that it could be something else. You might have two problems here. So what would you go with? What number would you assign here? Okay, and so why is that?
Because the presentation for discogenic seems to
Mm-hmm. But we don't have elbow pain increasing as a result. So now, the primary symptom generator of the form, you still think is cervicogenic, form throbbing increases with grasping and reaching. What does that do to your cervicogenic hypothesis?
Less likely.
It's less likely. So would we go -2 or -1?
We'll go minus two.
Okay. Primary symptom generator of the form, you still think is cervicogenic. Reading for 15 minutes increases scapular pain and thumb paresthesias, but does not change the forearm throb.
Sounds like two things,
Yeah.
two issues.
Seems like there's a P1, P2.
Okay? So this is what you do every day. When you try to correlate and dissociate symptoms, this is what you're thinking. You're ranking the way you're thinking. Okay, so patient turns head to the right, ×1. I just said, go to where you feel a change in your symptoms. Gets a brief shot of scapular pains, forearm throb escalates for 5 minutes. And it takes that long to settle down.
What does GOOP stand for again?
Get out of position.
Get out of position.
Get out of position. Get out of position. You have to emphasize the first
Nowadays,
part.
in our notes, that should just be your smart phrase to where it automatically populates. Get out of position in your note. Don't put GOOP in your note.
Well, that's very disappointing. Okay, reaching arm forward while holding a cup of coffee ×1 escalates his forearm throb ×5 minutes, rather. So he has two things, a contractile thing and a cervical thing. Why do you think this hurts? What are things that come to mind, like why would it hurt if it's a C-spine problem for me to do this?
It might be impaired neurodynamics, so just putting that on stretch.
Okay, so traction's a nerve. What else?
Muscle tension, all your soft tissue is gonna pinch things.
Could be that. What does the brain do when it thinks pain's here?
Focuses on the area.
Do you think the extensor musculature turns on and doesn't relax? Yes. So your brain reacts to a site of pain by saying, we're locking that down. So it's conceivable that you end up with just myalgias in that area, if you will, and then it makes the neurodynamic component even more kind of demanding. So you have a neurodynamic issue here, and you have one here because nothing around that extensor group is moving. Okay, then reading for 15 minutes gets the scapular ache, onset of thumb tingling, eases in 20 to 30 minutes. So far, would you say he has a severe condition based on what you're seeing? We haven't crossed into irritability yet. Okay,
P1's pretty.
so the pain seems pretty bad. What about irritability?
seems for sure.
Would you say he's min, mod, extreme irritability? Turns head one time, gets out of the position, he has forearm pain for 5 minutes.
Usually modded, extreme.
Okay. So, I mean, this guy, right, remember, the amount of activity that it takes to bring symptoms on, how bad they get, and then what it takes to have them de-escalate. Here's his 24-hour behavior. What do we think about severity now?
Extreme.
Did you say it's extreme?
Yeah.
Okay. So he's medicating with narcotics, he's doing a lot of things to get a good night's sleep, and he can't even lay in bed. He's got to sleep in an easy chair, and that's a pretty common thing for people with the cervical ridic. Okay, here we're back at script concordance testing again. So you still think it's cervicogenic, the forearm throb was notable symptom and pulling heavy, okay. Forearm throb was notable symptom and pulling heavy wire was the only known precipitant. So this is just talking about his current history now. So he's like, this is my worst complaint, and what I was doing was just pulling wire through their portals. He was working, I think, at a commercial project of some kind. That by itself, at face value, what would that do to your cervicogenic hypothesis? Even though you know this is cervicogenic at this point. But if you were just looking at that, would it do anything to the numbers?
Put it at 0.
Are you all good with that? Doesn't
His
help.
first symptom of all of this was his forearm.
Well, in this scenario.
And it came on with activity that is repetitive to stressing the forearm tissues, correct?
Mhm.
That's what you're saying? Okay.
Yeah.
I would say it would make my cervicogenic go down slightly.
Yeah. Okay, so primary symptom generator of forearm pain you're thinking is lateral epicondyle. Forearm throbbing is the only symptom, gradual onset during 2 days of overhead work. And think about what electricians do. You're like this, right? You're working overhead. So what does it make you think? What am I doing right now?
Extension on the neck.
Yeah, so I'm closing down my vertebral foramen pretty significantly. So I guess the question would be, does this affect your rating at all over here? Or is it equivocal? Does it change anybody's mind? Think, oh, it's gotta be more forearm, gotta be more cervical.
Maybe a +1 for me, only because you're in that sustained position for
Yeah.
a while.
So it could really back up your cervical spine hypothesis a little bit. Okay, you're thinking the primary symptom generator back again to the forearm as being cervicogenic. Onset of neck stiffness, scapular pain, paresthesias was 4 weeks after the onset of the forearm pain. At face value, does that help you? Again, even though you already have behaviors that are pushing you that direction, that it's all related. So the reason this is in here, this is a very common presentation, is you'll have some peripheral pain of some kind, then it's like rears its ugly head. It's why it's so important to ask, what was the first symptom that you experienced, particularly with a protracted onset like this? And so usually it's something like the scapular pain is what they notice, and then all these other things come along. That wasn't the case. So you can't say, gee, I still think the forearm pain is part of the cervical spine. This doesn't help you with that. The things that help you are the fact that, turns his head or whatever he does, brings his symptoms on, and you already know that from behavior. So here's his real current history. Go ahead and read through it. So this is an easy scenario, isn't it? This is like, okay, plus two, plus two, plus two. We saw AFM, he got some meds, which you had seen there, Flexeril, Norco, and what was it, Motrin, and he got referred to PT. Here's his relevant past history. So he's two or three episodes of Rhineck. Rhineck means his neck is kind of stuck and he can't get back up to neutral. And that can be because of a facet or it can be because of a discogenic problem, either one, but they're distinctly different in their presentations. And so, you know, he says spontaneous resolution for each episode. He hasn't had any trauma, although when you think about micro trauma, what electricians do for a living, you know, having worked with a couple of them over the years, their jobs are tough. So, although they make a lot of money, so I don't feel really sorry for them. So here's his health screen. Take a look at this.
Michael, your check marks mean negative.
Means okay, everything's fine. Sorry, checks mean everything's fine. Wish we had checks in our chart. We can't be all correct.
What's
Okay.
the
So
NLS
check.
again?
Huh?
What's NLS again?
Normal limits. And that is something that's in the medical record, I think. Isn't it? NLS. Remember we had some big lecture in 2006 when Health Clinic came out, you can't use any abbreviations anymore, but
Like period, just eliminate all abbreviations.
yeah.
So cough and sneeze, it means he feels okay with cough?
Yes.
No pain, no repercussions.
Yeah. Okay. And of course, you know, when we ask our patients that, you probably should say, by the way, have you coughed or sneezed recently? Sometimes they haven't. So what are things that jump off the page at you that might be challenges going forward as far as his prognosis?
No, he's a smoker, he smokes half a day.
A1C.
Yeah, so his sugars are elevated a bit. At the time, I think A1C acceptable at that time was 6.1 or something. Now it's down below 5.9. But he's, you know, the smoking is the big problem because that is going to rob his nerve, those little capillaries that are being narrowed from oxygen to begin with. And you can't tell them you got to quit smoking, but you can tell them what the ramifications of that are. Just so you know, this is a situation with that nerve, and nicotine is not going to help you get better quickly. So, choice is yours. Just you need to know. And then he's 41 years old, so he's got elevated blood sugars. He has borderline hypertension. The fact that he's on Motrin TID will probably escalate his hemoglobin A1C and his glucose level in the bloodstream. So all those things, even though that's necessary to control his symptoms, he's probably adding a little bit to that. Okay, so what are we going to do about examining his C-spine? So these are his symptoms, elbow and scapula. And, oh, I'm sorry, this is for severity. So severity, you all agreed, are we saying he's extremely severe? Okay. What about irritability?
Pretty irritable.
Yeah, he doesn't do much. And it brings on pretty significant pain, and it takes a while for it to ease up proportionally. So is your initial hypothesis that C5-6 discogenic with a right-sided acute C6 radiculopathy still your primary? Okay, good. are you concerned about it? Meaning, does the nature of the problem make you concerned? And then I guess the question would be, how does an information affect you? So what do we know about the nature of nerve injuries? So when a nerve gets compromised enough and you have axonal degeneration, what happens?
Some essentially changes.
Yeah. So you have functional loss, motor change, sensor change. And he's not there yet. So he's still, as far as we know, we haven't done many muscle testing on the guy, but it should warrant concern. And, letting him know that if he starts to feel weaker or he starts to feel actual loss of sensation, that you need to know, because something would need to be escalated at that point. And maybe you even decide, we need to escalate this now. That's your decision, depends on what you find in your physical exam. But if you were able to follow up with him frequently, this is the kind of person you probably want to keep a lifeline attached to, then you're always going to recheck your neuro that fits his situation, because if you see it start to decline, then you're escalating as well. Do we think he's inflammatory? Dominant at this point? It's kind of a given, isn't it? Do we do a neuro on this guy? For sure. And so we'll talk more about this in a day or so, but you're going to do a segmental neuro, so where you're analyzing all the different nerve segments in the C-spine, and you might even want to throw in the central nervous system screening, just to be sure that, you can do Hoffman's, you can certainly going to look at refluxes, and if you think it's warranted, you can expand down and do a Babinski and things like that, depending on what he tells us. He has no complaints of gait disturbance or anything like that at this point, so maybe we don't need to go that far day one. The stage, even though this has been going on for a while, this is the hard part about staging. He still seems like he's an acute, and so that hasn't really changed. And so I think we would use that terminology here. The stability of his condition, would you say he's staying the same, getting better, getting worse?
Getting worse.
Yes. And then, do we think there's anything special we need to do? And the answer would be no. Just the fundamentals is what's important here. Do you think that we'll be requesting diagnostic studies, like an MRI of the C-spine? Would you say, let's do it now, not wait?
I think it would depend on further examination, like how his function is,
Yep.
reflexes and all that.
Totally. And then the question to him would be, if you want to get an MRI, how much is an MRI going to cost him? Even though, we think health is health, you got to do it, but many of our patients are paying like the full Monty for MRIs these days, so that's how their insurance is set up. Okay, and then as far as intervention goes, what do you anticipate what would be probably the most aggressive thing you would do with this guy if you're going to intervene? What's a safe bet with somebody with a ridiculous?
Gentle traction, maybe.
Yeah. And gentle being the operative word. Okay, so I think you're going to know the answer to this right away. How far are we willing to let him go when we do movement testing? Yes. So right rotation brings the symptoms on. Let me see it. Okay. Oh yeah, there it is. My arm now. That's going to be there for 5 minutes. Right? Let's go the other way. Tell me what happens. If he says, oh, that actually is somewhat relieving, then maybe you have a shot at maybe giving him something as a home exercise that would be helpful. Okay, here he is. A beautiful human being with a cow tattooed on his left arm. Looks like an electrician, doesn't he? Whatever electricians look like, stereotype them. Okay, so he likes being up there. So that does what? If you had a script concordance test in front of you and it said that his arm was overhead, you would say, yeah, this kind of confirms what I'm thinking. Here's his neurotests. So what do we know already? Is this confirming your hypothesis? Yeah, he's got denervation, at least as far as we know, of supinators, shoulder external rotators, even though this is not your typical test, but this would be. And he's got a diminished sensation in his thumb pad. So everything's lining up. And you're thinking, okay, he's got active denervation. We don't know for sure. Maybe part of this is inhibition, but you don't get that weak from just inhibition in most cases. And his DTRs are sluggish, really in both of these areas. I mean, biceps has some C6, and brachioradialis is, of course, C6. Does this concern you? All right. Not really? Okay. Well, it's concerning in that you don't want him to progress. Because if he denervates more, then he's looking at a much more protracted recovery of the nerve. Oh, great. Okay, I know what's happening. It's not going to stop. Hang on a minute. Oh, there he goes. The problem is these MPEGs, I'm not kidding you. I took these these videos of him with camera that you put a floppy disk in. State of the art at the time. So, okay, so because this patient, you couldn't get them recumbent. Pretty much everything we did day one was in sitting. Okay, so we know that he had easy reproduction of symptoms with 2 movements. I probably didn't need to do cervical extension on him. I could have picked one thing and then looked at something that was a little bit less risky to see if there was anything that he could benefit from. You know, there's local spasm over the right articular pillar of 5-6. He has a marked increase in scapular symptoms and elbow throb with gentle traction. But that's a bad sign. And it's not like I'm trying to do a lift off with him. I'm just unloading him a little bit. So when traction is super sensitive, it's usually something that, first of all, you're not going to do it as a treatment if you're increasing the symptoms, and then you have to figure out what we do to get him to settle down. So you're prognosticated now. The patient's condition should resolve nicely in 3 to 4 weeks. The condition is severe and irritable. What does that do to your prognosis? Does that make your 3 to 4 week recovery? Does that make your 3 to 4 week recovery something that seems plausible or not? Yeah, so high severity, high irritability are usually an indication of a very protracted recovery. Now, if he's a hammerhead and just like, I need to work, I'm going to do it, well, maybe he will get back to work, but it's certainly not going to resolve quickly. Same scenario, okay? The patient's a smoker, recent onset of type 2 diabetes. How does that help with you? prognosis of 3 to 4 weeks resolution. Yeah.
Okay.
Okay, same scenario with prognosis. The patient owns his own business, works alone, is unable to miss work. Not a lot of attributes here, right? Not a lot of personal attributes. So an explanation to the patient at some point is important. You know, when you're doing that educational 5 steps to education, the last one is prognosis. You know, like, here's the concerns I have. I think in the best case scenarios, you'd feel probably a lot better in 4 weeks if we can get you the right meds and do the right things in PT, but you have these other things, so I don't know how, I can't influence those. You have to. It doesn't mean you're the bad news bearer, though. You're the good news bearer. You're going to get over this, and I'm going to help you do this. We're going to do this together, but these are some things that are going to make it more challenging. So, you know, the first thing you think of is, let's get this guy a Medrol dose pack or prednisone taper, which is similar. The only problem is he's diabetic. And so even though he's not real diabetic, it's kind of, you know, recent diagnosis and everything, he would have to check his blood sugars, and it would probably want to put him on a diabetic medication so he could be on that while he's taking the prednisone. And that's, you know, introducing 2 medications at one time, even though our docs do that a lot. It's not necessarily the perfect situation. So, working hypotheses. I think we've kind of validated what our issue is. It's pain dominant, probably inflammatory. The short-term prognosis is not going to be sterling. And here are some of the barriers that he has, which we just kicked around. So this is what we did day 1. Contact with the PCP is like 6.8, it's not that high. Let's prescribe. It's only 10 days. And so he got a prednisone taper that goes like, you know, 60 milligrams, 60 milligrams, 40, 40, 40, 20, 20, 10, 5, and then you're done. But the blast off is in the first few days. 60 milligrams is a lot. And you got to tell your patients, you might feel your heart beating really hard at night. These are, you know, symptoms associated with prednisone use. And so tachycardia is one, flushing is another. It usually doesn't come on until the 2nd day. And insomnia, and a sense of euphoria and endless energy. Particularly in younger people, when they take prednisone, they get pretty fired up. So I can't tell you how many patients like, I cleaned my house, I'm like, what? You're supposed to be resting, right? So this cervicothoracic unload tape job, which you'll learn soon, is money for all cervicogenic issues, particularly disc problems, radics. Usually with the radic, it's combined with an unload of the upper extremity as well. But even if they can only wear this for 24 hours, but we tell them to wear it for 48 if they can tolerate it, it kind of takes the tension off the nerve, gives it a little bit of a break while you're getting medication on board, and can really kind of help jumpstart the situation. So, prednisone is the kind of the preferred thing. Medrol dose packs, this is Decadron. I'm sure you've had patients in the hospital getting Decadron. That's super potent. And so prednisone is usually the place to start with. All right, so how we progress our intervention, first of all, we're going to reassess at each visit, his neurostatus, his range of motion, his tolerance to traction. Because once he can tolerate traction, we can start doing it therapeutically. In most cases, what we have is like somebody like this come back 10 days after they see you because they are then tapering off of their prednisone. And so, you know, this is obviously very rudimentary, but we're doing some manual traction, progressing to, at this point, we don't do this anymore. We don't have a mechanical traction table. We have those Saunders pneumatic traction units, which are almost as good. The nice thing about this is you can cycle on and off or part way off. It was a pretty nice situation. And then got him doing towel traction at home. Towel traction is a really nice way of maybe getting up to 10 pounds of traction into the intervertebral segments. And you can palpate separation posteriorly with this. You have to have a patient that's reliable. That's the only thing. They have to have some motor skill to do this. Sorry. Okay. So then, as time goes on, you get into working on the thoracic spine and then eventually targeted treatment and then targeted exercise prescription, things like windmills and things to keep this thoracic. As you can imagine, anybody who works in the trades has a horribly stiff thoracic spine. If he's going back to working overhead and he doesn't have any mobility down to T6, then it's all going to be happening in the impaired levels. And that's a recipe for coming back again. So,
And he's also a mountain biker, right? Which puts him in this position all the
Yes.
time too with the trepidation.
yeah. So this is kind of a scenario of kind of how you would look through things and sift through things. The intervention part's not the important part. The mental process that you just went through is really what's important as far as subjective and physical exam. Okay, so I'm gonna shut this darn thing off and we're gonna go into the shoulder clearing exam that'll kind of get us jump started into our composite lab for C-spine. Okay? So I'm going to, have you guys been told about the heater in here? No. Okay. So if you turn it up or down, it usually overcompensates. So I'm going to try and turn it up a degree, which means it'll probably go up 5 degrees. But let's see. And the funny person would be Bobby. Bobby would say, "It's so